I think Dr. Natarajan likes this talk, I think, for the philosophy rather than for the science.
No, but the idea of introducing science to
Yes, but I think this is a very important talk, so I'm always happy to deliver this again and again. See, the very fact that you have an I in the talk means it becomes personal and philosophical, and it no longer stays scientific. And we've discussed this before. Why do people write papers? You might be forced to do it. There's academic arrogance. But 1% of papers are to discover the truth. And these are the papers we tend to admire. But the whole question is that how is the true path revealed to us? How do you know that a paper that you are actually reading is the truth? Right? If you see any disease which is being treated today, the treatment is different from 20 years back. You take cancer breast. It started off with simple removal of the lump in 1850. Then it became radical mastectomy. Then it became supra-radical mastectomy and ultra-radical mastectomy. The more nodes you remove half the chest wall with it. Then they realized it's not worth it. So then they went back to radical, then modified radical. Then you're back to breast conservation, which is the same as what was 150 years back. So that every 20 years, the surgeon feels he's doing the right thing, based on what is the current data. So how do you know that you are actually at the true paths or the true success? So do you believe your teachers? Do you believe your peers? Do you believe textbooks? Do you believe peer-reviewed publications? A lot of papers may not show us the truth. And you already heard so much about confounding factors from Dr. Mulil, that if you just omit to write that these confounding factors were present in my study, you might believe that the data is actually truthful. And all your papers, however good they might be, have some form of bias. It might be the drug company biasing it, it might be your selection, and there are 32 different types of bias you can actually encounter. And even if the truth is staring at us, we may not want to accept the truth. And I've just put up this paper to show you. Marshall and Warren, you're all familiar with them. 2005 Nobel Prize for the discovery of Helicobacter pylori. When they went to publish their paper that, we did so many endoscopies and we found Helicobacter pylori in the stomach, nobody wanted to believe that a microorganism can cause acidity and peptic ulcer disease. No one would publish their paper. Ultimately, it was published in the South Australian Journal of Medicine. The first Nobel Prize winning technology paper was published in the South Australian Journal of Medicine. It is not even in PubMed. You can't find that paper. Because nobody wanted to believe the truth. And wonderful, clear, scientific, truthfully done research was not published because the peers would not believe that this was truthful. So I believe that a good study is not only a study that is not biased, but can clearly be seen to the rest of the world that the study is not biased. So you've demonstrated it. This is the first randomized control trial, streptomycin treatment of pulmonary tuberculosis, done by the Medical Research Council. So, this is evidence-based medicine and randomization. Now, this I found a very interesting paper, and the history behind this is interesting. Today we consider RCTs as level 1 evidence, the best way to do studies, blah, blah, blah. In this era, RCTs were considered to be unethical. How do I toss a coin and decide whether someone gets treatment or no treatment? The reason why the streptomycin study became a randomized trial was that there was a limited supply of streptomycin available to the people who were going to do the study. So, because of the World War, they had only 50 kilograms of the drug. So, if you wanted to see whether it acts in tuberculosis, a lot of debate was held by the great medical doctors of the time. Should we give it only for the very sick? Then they say, no, we'll never find out. Because even if it works, a lot of people might die because they're very sick. Then should we give it to the well who are likely to survive? Again, you're going to run into a problem because some of them might recover because of their own immunity. Because in the days before streptomycin, the only treatment was to put them in sunlight in a nice warm part of England, wherever they might be, and hope that they actually recover. So at that point, they decided that we have a limited supply. We cannot give it to everybody. So the only way to do it is to randomize. And that came the birth of this sort of science. So that is interesting how our concepts about what is a good study is changing. In those days, they frowned upon RCTs. Today, we look upon it as the holy grail. Surgical studies, and I'm a surgeon, a lot of you in the audience are surgeons, have a peculiar problem. Is there are so many new procedures coming. There is no uniform skill dependency of surgery. A surgical outcome might be entirely different because one's a ham-fisted idiot and the other is a master at his work. Patients always have a perception of best choice. Today, try convincing someone not to have a laparoscopic surgery and see how far you get. There is an element of patient protection involved. How do you blind a patient for surgery versus placebo? It's a very interesting ethical concept. And how do you take consent for such things? So actually doing a scientific, unbiased surgical study is something that's extremely difficult, which is why I have chosen this paper to highlight. This was published many years back, 1996 in The Lancet. Randomized prospective single-blind comparison of laparoscopic versus small incision cholecystectomy. Now, lap chole had come in a big way. And the entire industry of laparoscopic instruments was pushing it tremendously because there were millions and millions of dollars of investment if everyone took it up. The number of cholecystectomies in America had trebled over 3 years just because everyone was rushing in, small incision puncture, get the gallbladder out, we all want the surgery, go for it. So it was assumed that laparoscopic surgery was better than open surgery. And that is what the authors of the paper said, that surgeons deem an evaluation as ethically unjustified. It is so obvious that laparoscopy is better, how do you ethically study it? And this was due to this obvious advantages and investment by instrument manufacturers. So this is in the introduction to their paper. Now, trials which have been published did not take into account the effects of the belief of the patient. If you believe enough that you will be cured, it doesn't matter how the study is done. You will say, yes, I have got better. So you had to design a study which took away that belief from the patient so that you can accurately measure outcomes. So what did they actually do? So 4 surgeons operated and they had equal experience in laparoscopic and open surgery. So they were well-trained laparoscopic surgeons. To eliminate the bias of operative expectation after the patient was anesthetized, they opened the sealed envelope which told them, are you going to be in the laparoscopy arm or the open arm? And the surgeon was equally skilled at doing both. And the trial folder was kept separate from all the other records. So outside OT, no one knew which arm they went into. But obviously there's a difference between the big cut of that open surgery and laparoscopy. So they did this form of dressing. I don't know whether it projects well to you. So they put a big bandage across what you would have in the open surgery. And they put these 4 small bandages what you would have in the laparoscopy surgery. And they put spots of betadine on all 4. So it mimicked blood oozing from the incision. So when the patient looked at his abdomen, the sister looked at the abdomen, the person coming to take their pain score, time to recovery, if they looked at the tummy, it was impossible to say whether the person had an open surgery or a laparoscopic surgery. So that bias of expectation that because I have a laparoscopic surgery, I'm going to go home faster, was taken away. So this is the extent of the design. And a research nurse was unaware of the operation, was made responsible for collecting data on recovery and time to work and whatever. And the patient decided, when should I go back to work? That was entirely up to him. So the analysis was done by the usual techniques and look at the outcomes. There was a difference in operator time, which is to be expected because we all know laparoscopic surgery takes a little bit longer. You have to set up all the equipment and everything. The time to first feed, hospital stay, time of work, return to full activity was absolutely similar between the two groups. There was no difference at all. Complications were similar. And what they demonstrated that it was possible to do a randomized surgical study where you can eliminate bias for or against the procedure. And at the end of it, they concluded that we could not demonstrate a benefit for laparoscopic cholecystectomy above the mini incision open cholecystectomy. Good studies always stand the test of time. So if you look at this Cochrane review, this was published in 2009. This is a similar meta-analysis of all the studies on the field, and they have also concluded that the laparoscopic and small incision open cholecystectomy are equivalent. So when they added up all the studies and they did their meta-analysis, they found that good quality studies were added. This no difference still stands the test of time. Right. So we come back to the I word, personal and philosophical. So would I still consider this a paper that I would love to do and a paper that I would love to write? I will call this the Mona Lisa paper. Beautiful, technical perfection, absolute work of art. But if someone presented you the Mona Lisa, do you have any use for it? You're not allowed to sell it. You can only put it on the wall. You're worried that someone's going to come and steal it from your house. And what is the utility value of this? Has anyone stopped doing laparoscopic cholecystectomy because this paper was published? Has anyone stopped doing laparoscopic cholecystectomy because this meta-analysis is there? The answer is no. And why is the answer no? The answer is I don't care how my patient is getting better. As long as they're getting better and going home faster, I don't care whether it's their psychology making them do it or my surgery making them do it. As long as they're getting up and getting out on day one, I am happy. Isn't that so? So, I still carry out something in spite of magnificent evidence saying that there's no difference between the old-fashioned and the new, for the simple reason that it is what happens to the patient in the end which matters, rather than what is the great publication or what is the great paper telling me. And we are getting quicker and better. So the more laparoscopic cholecystectomies we do, the better we get. So if we did this study today and not in 1996, we might find that the operative time is less for the lap chole than the open, because we are struggling today to do open cholecystectomy rather than the lap. And that study, of course, will not be done. So what is the beauty of evidence-based medicine? Evidence-based medicine is the use of mathematical estimates of the risk of benefit and harm from this high-quality research on a population sample, which will help me make a decision in my individual patient sitting in front of me. All this research is worthless unless I can take value from that to treat the person sitting in front of me. So, a simple observational study might be something that I wish to do, because that can change the lives of people who are in front of me. And I put this example up here. 2 cases in the Lancet, and this is the full report in the Lancet. I've just cut and pasted it. You can make out how big this publication was. Identified the thalidomide baby. And people read this, and he asked this question: have any of your readers seen similar abnormalities in babies who have taken this drug during pregnancy? He asked that one question. And one gynecologist said, I've seen 2. One said, I've seen 1. I've seen 3. I've seen 1. And in 3 months, they gathered 10,000 such babies. And that changed not only the future of tens of thousands of similar such babies, who are born healthy because this drug was withdrawn. It changed the face of medical research on drugs in pregnancy. It changed the laws of clinical and scientific research on such babies. So, a simple report like this, a simple observation, is possibly of far more value than this magnificently designed, beautiful RCT I've shown you. And I would probably be more proud to bring something like this in front of you than the perfectly designed study for the impact it has made. But one more thing I'll tell you. Now, what has happened to Professor McBride after that? He became famous for fighting against the drug industry. And look at this. Thalidomide doctor guilty of medical fraud. The one who exposed the danger of one anti-nausea drug has been disgraced by experiments with another. So he went after the industry with vengeance. He picked on another drug called Debendox. He actually falsified his research because inside him he had the belief that I am here to fight against the drug industry and my reputation depends on that. So he believed so much in his own work that he altered his data. He developed a bias within himself, and ultimately he was disgraced, and the Supreme Court in Sydney actually took him to task, and he was stopped from doing any further research. So you must not be carried away by the work you do. Scientific facts have to remain objective, and your own personal feelings cannot really come into the picture. And a simple idea, it need not even be research, can be enough to change millions of lives. And I put one such paper in front of you, PKCT. I'll just take 2 minutes more. Rubber foot for amputees in underdeveloped countries, Journal of the Bone and Joint Surgery. Such a simple development. Indian patients need to squat. Foreign foot will not let you squat. Foreign foot costs 1,000 pounds. Indian foot can be made for 1,000 rupees. Local benefit enables squatting, durability, cost. Allows a man to go barefoot. It looks like a foot. So the other foot need not have a shoe. Foreign foot had a shoe because Westerners always wear shoes. So simple thinking like this has changed millions of lives, primarily in countries like Afghanistan, Iraq, where there have been those landmines. And, so many people have had their legs blown off walking on landmines. All have been fitted with this foot. So what is the ideal paper I wish I had written? Is it strong evidence-based medicine? Is it a simple observation or a simple idea like that? It can be any of this. So anything that actually tells the truth, anything that advances patient care, anything that advances basic science is something that we need to be proud of and something that we should do. As long as it is truthful, it will stand the test of time, and that is the research we should aim to be doing. I'll just stop at that point.
Thank you. And usually you used to tell a story about this king in Israel, I think. I forgot. No, you can tell that, but I think that's it. No, it's okay. 5 minutes, fine. No, that story is important. I think very good.
Okay, so this was the story of the first randomized control trial. So I think
yes.
I think it is a well-known story. So there was this king in a country which is now Jordan, and he was told by his doctor in that day that exercise is good for you and it aids your digestion. So he said that yes, it's a very important thing. He's probably a lazy chap. So he said we must study it. So he took 2 nights. So one of them was given a feast. One of them was kept, light diet, and both were told to. Both were given a feast. One was told you have to lie in bed. The other one was told that you go hunting, go horse riding, go all over the place. 8 hours later, both of them were killed. Postmortem was done, and it was seen how far the food had progressed. So it was seen that the one who had done a lot of physical activity, food had reached the ileum. The one who was lying in bed, food had just reached the jejunum. So he told his doctor, yes, you are right. Exercise does aid digestion and helps in progression of food to the gut. And you are right. So the message of this is it was a very good randomized study, but I'm not sure about the ethics of it.
Mm-hmm. Any questions? Thank you, Sudeep. Any questions? And he also mentioned about the paper from Maharashtra on the scorpion bite.
We can keep going on and on about
No.
papers,
I think that's what will probably stimulate to say from any remote place you can make it.
This is a Lancet publication by a rural doctor who had a simple hypothesis that his anti-blood pressure drug can help people with scorpion bites. And that has come in the Lancet. And there are, great professors who are unable to get publications in Lancet. So a simple idea, an original thought, rare illness seen locally in your area, something which you feel might work, an observational study can actually make a great publication and can help hundreds of similar patients. So which is the bottom line? As long as your data is truthful, you're bound to help people, and that merits publication.